Our gut is like the engine of our body, turning nourishment into energy. When there's a problem with that process, it can not only cause uncomfortable sensations, but it could be life-threatening. Belly pain and gut health. Tonight, On Call with the Prairie Doc, celebrating our 20th season. Welcome to On Call with the Prairie Doc as we celebrate our 20 seasons of truthful, tested, and timely medical information. Joining us tonight here in our studio on the South Dakota State University campus in Brookings is Dr. Cristina Hill-Jensen of Avera Medical Group Gastroenterology, Sioux Falls, South Dakota, and Dr. Teresa Trudeau from Avera Medical Group Specialty Care in Brookings, South Dakota. Welcome to both of you.
Thank you.
Thank you for being here.
Yes.
So we're going to tackle any kind of belly questions today. We've got a gastroenterologist and a general surgeon. I think we're ready to go. Let's start. It's kind of a hot topic is that our guidelines for colon cancer are recently changing. Christy, can you tell us a little bit about how that's changed recently?
Yeah, so we are now going to age 45. So it's an exciting thing. 45 for men and women, and we're also extending the age as well. So instead of saying, okay, stop at age 75, we can go all the way up to 85 if appropriate. So these are really great changes, and I'm excited. Your insurance, it should be paying for it. So yep, we're excited to get all these patients in because we've seen a really, unfortunately, a sharp uptick in patients younger than 40 with colon cancer.
Yeah. Do we know anything about why that is, Teresa, or it's just we see the data and we're responding?
I think it's more that we see the data and we're responding. I also think it's multifactorial, our diets and the environment that we live in these days.
Yeah. And colonoscopy, like people are kind of scared of this sometimes. From what I understand, everyone hates the prep. Can you tell us, like, has the prep changed?
There are
since
some,
maybe some people had their last one 10 or 20 years ago.
I think so.
Yeah.
I think there's some better alternatives. We have a smaller volume prep. We do a Gatorade prep. You mix some Miralax with Gatorade, and we split dose the prep, so you're not consuming this whole gallon of prep all at once. So I think it has been better.
Yeah. It seems that people are responding that way. Let's start with some questions, and we look forward to answering your questions about tonight's topic, belly pain and gut health. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. And to encourage your questions, those of you who ask a question during the first 20 minutes of tonight's program will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of the program. Your question will remain anonymous, but be sure to provide your name and contact information when you submit your question so we can contact the winner. So we do already have a couple questions. I've got an email from a viewer in Mobridge. Is it normal to have several forceful, loose stools a day? And should I be concerned about that? You want to start, Christy?
Well, we say a normal stool pattern, 3 per day to 3 per week. The forceful part I would have to ask more questions about. So I would say definitely go talk to your primary care provider, and then he or she can point you in the right direction with that.
Yeah. Sometimes sorting out what's on the spectrum of normal versus abnormal, especially when it comes to stools and diarrhea, is hard, isn't it, Teresa? Like, what are some red flags? What things should a patient really not wait to come talk to their doctor about when it comes to stool pattern?
Well, definitely the colors that should be red flags would be if you have red stools or black stools. And then from the surgical standpoint, if you have white stools, that also concerns me as well.
Sure.
Now in stool pattern, it's really kind of how the person feels. So like if they're having 3 bowel movements a week and they're super uncomfortable with it, or it was a change in their bowel habits, then that's concerning as well.
Sure.
But if they're used to having 3 bowel movements a week and they're not uncomfortable, then that can be completely normal.
Right. Do you have anything to add?
Nope, I would agree with that.
Yeah. We have a person who's watching on Facebook who asked, why are fermented foods supposed to be good for the gut? Do you have anything on that, Cristina? I think there's a lot of stuff out there about foods and gut health. What's real?
Well, yeah, and it's hard. I mean, when you're walking through the grocery store
Right.
and you see this, cool headline, you can't necessarily believe that. But
Right.
we do believe fermented foods feed the healthy bacteria in our gut, or what we call the microbiome or microbiota.
Right.
And so that will help with digestion.
Are there certain foods that really are bad for gut health, Teresa? It probably depends on what your issues are, right?
Right.
Yeah.
I would say it depends on what you're experiencing. There are people who have had, say, a cholecystectomy, and then if they eat higher fat foods, that they end up having diarrhea. And so it really just depends on the person if there's really bad food.
Yeah, yeah. And there are certain food intolerances out there, and how do we sort some of those out?
Well, I think the easiest would be an elimination diet.
Yeah.
So, taking dairy out, which is the most common. 40%
Right.
of Caucasians will lose the ability to tolerate dairy.
Yeah.
Gluten, as well, is unfortunately another food intolerance. And we have certain testing as well where we can check for food intolerance also.
You mentioned dairy as a big one. And so common, right? And some people, I think, have the misperception that they can't get lactose intolerant later in life. So that happens, right?
Yeah,
in adulthood?
it's very common to lose the ability for our lactase enzyme to actually break down lactose. So no, so it doesn't have to be, well, I could tolerate milk as a child and now all of a sudden something's different. It doesn't have to be, well, I couldn't as a child. So yeah, it is something that we can see as an adult ages, absolutely.
Yeah, great. We're getting some more questions in. So a caller from Rapid City states that they were diagnosed with H. pylori. So let's start there. What is H. pylori, Teresa?
So H. pylori is a bacterium that can be found in your gut, and it can cause a lot of problems such as gastritis, gastric ulcers, and it has also been linked to some cancers too. So
Yeah. So this person states that they got it. They lost a bunch of weight. They were on antibiotics after they were diagnosed. Is there a blood test to look and see after you've been treated, if it's been treated? It sounds like they're still having some symptoms a long ways out from treatment. So let's start with, I guess, how do we treat H. pylori and how do we know if it's gone?
So it's a combination of medications, and it really depends on the area of the country you're in, because there's a high resistance to antibiotics. So it's commonly 2 antibiotics in combination with a medicine that will decrease acid. How do we know if we've eradicated it? Well, in about 10 to 12 weeks after treatment, we will then perform a stool test to see if there's any presence of that H. pylori.
Yeah, good. So the stool test is probably the best for making sure that it's gone. We have a woman from Webster who feels very bloated no matter what he eats. What causes bloating and that symptom?
Oh, that's a very hard question. There's just so much stuff that can cause bloating and that symptom, and everybody kind of describes that symptom a little bit differently, and so it's really hard to just kind of say what causes that.
Yeah. Are there concerning things that can cause bloating, Christy?
Well, I mean, if it goes back to perhaps a major change in your stool pattern and now you feel as though you're tight like a drum and you can't pass stool, I would be very concerned with that. If you start to have very strong smelling belching that smells almost like stools, I'd be concerned about that.
Yeah. Okay. And tell us a little bit about the different procedures that we do to help diagnose. So we talked a little bit about colonoscopy. What's an EGD or an upper endoscopy?
So an upper scope is a long, flexible tube with a light and camera on the end of it. The patient is asleep on his or her side, and then we slip the small scope, about the size of my finger, down the back of the throat into the esophagus, and that way we can visualize the esophagus, stomach, and the first portion of the small bowel or duodenum. It's a pretty common procedure. Yeah.
Why do we do that procedure, Teresa?
Well, we do it to look for anything that could be going on in the upper abdomen in terms of if the person's having abdominal pain, sometimes for bloating, also following reflux. If a person has had Barrett's esophagus, that would be another reason to do it. And so those are some of those reasons.
Yeah, good. And so we have good ways to look at that first part of the gut. We have good ways to look at the colon. And then there's this big part of the gut that it's harder to look at, right? The whole small bowel. So what do we do if you have concerns that there might be something going on in the small bowel?
Well, there's first some great X-ray type studies, a special type of CAT scan called a CT interrography, an MRI called an MR interrography. But what we like to do is called a pill camera or video capsule endoscopy, and it is a pill the size of a vitamin that has a camera, a flash, and a battery, and it takes 60,000 pictures of the small bowel.
Wow.
But the nervous part is it could get stuck, right, if there's something abnormal in there. But that's a very rare thing, fortunately, and we have to do it in the right patient.
Yeah, good. Prairie Doc physician Andrew Ellsworth talks about the importance of getting a colonoscopy procedure early to avoid future complications. Prairie Doc reporter Esther Michael spoke with Dr. Ellsworth about the procedure.
Colonoscopy is a procedure used to help look for cancer or an abnormality in the colon. A flexible colonoscope is used to go into the rectum and into the large colon in the intestines, the bowel. The scope is up to 5.5 feet long and is quite small, I mean maybe the size of my finger, and flexible.
Dr. Ellsworth says many patients shy away from colonoscopy preparation. However, talking to your health provider may help create a smoother preparation before the procedure.
Colonoscopy is recommended now for everyone starting at age 45 to help detect colon cancer early. It's also recommended if someone has rectal bleeding or blood in their stool, black or bloody stools, abdominal pain, diarrhea, or maybe if they have a strong family history of colon cancer, they may want to have a colonoscopy earlier than age 45.
Patients should be hydrated during preparation for the procedure. They should not hesitate to ask their health provider, so they may suggest a more gentle alternative.
The colonoscopy procedure often takes maybe half an hour or less, sometimes up to an hour. That can depend if how many polyps there are or the reasons for the colonoscopy. It's done as an outpatient procedure, so often you'll come maybe an hour or so before the procedure, have it, be in recovery for half an hour or so after the procedure, and then go home. We recommend having someone else drive you home because of the anesthesia. Oftentimes a person, once they wake up, they're often feeling back to normal and can eat something and go home and might not have any symptoms.
Ellsworth says risk of a colonoscopy procedure may vary, and to be on the lookout for any post-surgical difficulties.
As with any procedure, there's risk of infection or bleeding or pain or discomfort. There's always risk with anesthesia. The anesthesia is sedation, so it's just a matter of giving you a medication through an IV to help you sleep, and then it's turned off and you wake up again. Risk from the procedure, from the colonoscopy, the biggest risk would be perforation. That rate is quite rare and less than 1 in 1,000. Sometimes nothing may need to be done, but sometimes that could require surgery as well. That could happen from a hole or a puncture or tear in the colon during colonoscopy. There'd be risk of bleeding from having a polyp removed, and that bleeding could occur right then or sometimes could occur weeks later, so that's something to watch for after a colonoscopy.
So that's a little bit of colonoscopy. We use this often for colon cancer screening. Are there other options for colon cancer screening, Christy? Yeah.
So there's stool testing,
Yeah.
and so the Cologuard is one you probably see on TV advertised, but it is now kind of taking over, and it's a very good and reliable study. So perhaps if you're hesitant to undergo that full colonoscopy, please talk to your primary care provider about a Cologuard or other type of highly sensitive stool studies.
Usually when I talk to my patients about that, I make sure that we say, if this is positive, I'm going to recommend a colonoscopy. There may be a small number of people out there who just will never do it no matter what, but we want to make sure that they know that's a possibility. Are there people who are not good candidates for Cologuard testing? Maybe people that are not average risk? What would that mean, Teresa?
Anybody who is a higher risk
Yeah.
is not supposed to undergo Cologuard testing, and that would be somebody who has family history in a first-degree relative, or if they've had a history of polyps themselves. Also, if they're having symptoms, they should not have a Cologuard test. It is only for the asymptomatic people.
Yeah, good. So we're getting some questions in. I have a woman from Brookings wondering if we could talk about diverticulitis. She has it. She's wondering if there are suggestions on what her diet should consist of and any advice on probiotics. So I think sometimes there's confusion about these terminologies. So what is let's start with diverticulosis. What is that, Teresa?
So diverticulosis is the pockets that can be in the colon. Those are pockets that form along blood vessels because of tension on the colon wall. And so more common if a person has constipation, but even if you don't have constipation, people can develop them. Diverticulitis, though, is the inflammation of those pockets. And so a person can have diverticulosis and never have diverticulitis, but not vice versa.
So often people won't have symptoms of osis, diverticulosis, right? But what does diverticulitis look like? What symptoms do people usually get, Christy?
Pain in the left side and fever.
Yeah.
And it's considerable pain. It's not just, I maybe ate something, I feel a little uncomfortable. It's a considerable pain.
Yeah. And so often we'll do a CAT scan that helps us diagnose that. And usually mild cases are treated with antibiotics, but sometimes people like you, Teresa, the surgeons see them if it gets severe. So what happens with diverticulitis to lead to surgery in some cases?
So that's another thing that's kind of been changing in terms of what is recommended for surgical intervention for diverticulitis. It used to be that if you had 2 episodes of diverticulitis that you would be seeing a surgeon and talking about taking that portion of your colon out. However, now they say that if you are able to be treated with antibiotics and it's not very often that you're having it, that honestly you may not have to ever undergo surgery.
Sure.
Now there are times where you can have a complication with diverticulitis, like a perforation, which would make you have surgery emergently, or you might have to have a drain placed too if you have an abscess develop.
Yeah, good. So if you see people with diverticulosis on a colonoscopy, they're not having symptoms, are there things that you advise them to not eat? Is there good evidence with that, Christy?
No, there isn't good evidence. I mean, back in the 70s, 80s, 90s, it was don't eat nut seeds or popcorn, but we really have proven that that's not true. So we say a high fiber diet, staying active, and keeping weight down. Those 3 things have more science behind it than the avoidance of nuts or seeds or popcorn.
Okay. Good. And how about probiotics? Is there any role for probiotics in diverticulitis, or is there good evidence?
Still
in gut
not
health?
good evidence behind it, no.
Yeah. There's so much out there about probiotics. I think some patients do find that they feel better for whatever reason taking them, but we haven't found great evidence to recommend them strongly in a lot of cases, right? Good. There's a viewer from Flandreau who had surgery last June. This person is still having difficulty getting their bowels back to normal and using Miralax. So I assume they're experiencing some postoperative constipation. Is this a common thing that you see, Teresa? What happens to the gut after surgery?
Yeah, we can see a lot of either way, where it changes to more looser stools or even constipation. And there's just a lot of things that go into it, and it's hard to say exactly what's going on with that patient there.
Yeah. Are there things that you do first line for people with chronic constipation if you find that there's not a sinister reason for it? Christina, what do you think about Miralax, for example?
We love Miralax. It's been over the counter for 15 years. It's been approved for long-term use even in children. So we know it's safe and we know it's effective. And what I like is the patient can titrate the dose up and down. So, that patient will know his or her bowels better than I ever will. So he or she can have 1 dose a day, 2, all the way up to 4 capsules per day if needed. So it's a very good and safe medication to use.
Yeah, great. If you have a polyp in your gallbladder, should you be concerned and should you monitor it? So sometimes we'll find these on accident, right? The infamous incidentalomas. So what do we know about gallbladder polyps, Teresa?
So gallbladder polyps usually are like a collection of cholesterol that ends up being under the mucosa, and so then it ends up forming like a polyp. Also, there are some times where that it can be called a polyp just because it's not moving when they're doing the ultrasound. And so that can be more of actually just a stone that's stuck in that area.
So just something that's in the wall of the gallbladder. We can't really tell what it is on an ultrasound, and everything gets called a polyp. Yeah. Are there things about polyps that make them more likely to be something to be concerned about that would lead to a gallbladder removal?
The size,
Yeah.
Based on the size, but also based on the patient's symptoms. If they're having symptoms that are classic for gallbladder disease and they have a polyp, then our concern is this actually a stone that just was not moving at that time?
Sure. Okay. We have an emailer ask if there are any surgical procedures for a patient with severe GERD or reflux disease. So let's talk a little bit about reflux. What is reflux? How do we typically treat it? And then maybe we can ask about surgery.
Sure. So acid reflux, it's acid made in the bottom part of the stomach coming back up into the esophagus. We all do it.
Right.
It happens from birth until death, but it's when that bottom part of the esophagus, the sphincter, becomes weakened and more acid comes up. So traditionally we start with decreasing acid and allowing that sphincter to heal up and to tighten up again, and using medications that are called H2 blockers, like famotidine or Pepcid, or stronger medicines like omeprazole, Nexium, Prilosec. So we would give that a good 8-week trial and see how that patient does before they come into our clinic.
Yeah. And are there lifestyle or diet things that can help with reflux?
Yeah, absolutely.
Yeah.
Weight loss is a big one. Elevation of the head of the bed, smaller meals, avoidance. We talk about avoidance of the foods which can trigger that, highly acidic foods, decreasing coffee, trying not to eat or drink a few hours before bedtime as well.
Sure. And then how about surgery? I mean, how bad does it have to be to want to have surgery, and what exists out there for surgery, Teresa?
So it has to be bad enough that their symptoms, I would send them to you to have a pH and manometry study done to see exactly what they are having for acid coming up into the esophagus, and to quantify that a little bit more than just the symptoms that they're experiencing. And then also we check the musculature of the esophagus to make sure that if we do a surgical procedure on the person, that they're actually going to be able to continue to get food down. The reason being is because there's a few different things that can be done for surgery-wise, and one of those is the classic Nissen fundoplication, which is a wrap of the stomach around the lower end of the esophagus to basically recreate that lower esophageal sphincter. You can do a partial wrap if the person's esophagus isn't working well enough, and so that's why that manometry portion of it is so important. There are some newer things out now as well. They had started with some clips that was called the diff. I haven't seen a lot of people doing that around here, but one that's become a little bit more popular is called the Lynx procedure, which is magnets that are placed around the lower portion of the esophagus to again recreate that lower esophageal sphincter.
Gotcha. So there are some things out there for the very severe. We had a viewer ask, does the practice of intermittent fasting have any value for digestive health? Has there been research on that at all that you know?
There's been a little bit, and possibly it's good to kind of give the GI system a rest, but I haven't seen a lot of strong data yet.
Maybe in theory is the best that we have right now. Okay. We have a woman from Oneida who was diagnosed with a small abdominal aortic aneurysm 4 years ago at a screening event. What symptoms should she watch for, and how worried should she be? You want to take this one, Teresa?
Okay.
Depends on the size.
It depends on the size. The abdominal aortic aneurysms, the size is very important because once you get to 5 centimeters usually, and this is going back to training for me to tell you about this, but once it gets to 5 centimeters, then the risk of having it actually burst, it goes up significantly, and that's the point when we repair those. And so symptoms from it, a pulsatile mass, and so if you start feeling it a little bit more, I think that would be something to watch. But there are certain sizes that your doctor will follow it.
Yeah.
And so just be sure you're following up with your doctor on a regular basis.
Yeah, and that's what I would say too. You know, if my patient brought that screening to me, then we know we can look at it annually to see if it's growing and see if referral to a vascular surgeon would be warranted. Good. A woman from Sioux Falls is wondering if we could talk about SIBO, small intestinal bacterial overgrowth. How does one get this and how do they overcome it? This is a great one for you, Christy. Let's hear it.
So SIBO is kind of one of the popular terms now. So we all have a certain number of bacteria within our small bowel, and the role the bacteria play, I think, is very important, maybe even with immune type disorders. So when one strain flourishes, the bacterial balance becomes out of balance, and some symptoms would be problems with bloat, diarrhea, discomfort. How do we get it? Well, we think that some people who've had recurrent antibiotic usage, one strain will really flourish while those others perhaps are more suppressed. So we can test for that. One way to do is with an upper scope. We will pull out the aspirate from the jejunum, the bacteria. That's really not done, but we do breath testing for it very frequently, and that's something that I do in my practice. And then we treat with antibiotics depending on the type of bacteria, what they're producing, if they're methane or hydrogen producing bacteria as well. And then hopefully that person will start to not have diarrhea, not be as bloated.
Yeah, it's nice to actually sort of treat and kind of cure those people. I've run into problems with the right antibiotics being covered, though. Is that an issue that you see frequently with rifaximin?
Yeah, unfortunately, one of the best ones is extremely expensive. So we've got, you know, second choice, a third choice out there too.
Good. A Facebook viewer states she is taking pantoprazole for 6 months after having stomach pain and diagnosed with reflux. How long should she stay on the medication? Great question. What do you tell people about staying on their proton pump inhibitors?
So it's really, I would say, from my standpoint, a case by case, you know, thing. It is one that if they're able to get off of it, I would try to get them off, you know, as quickly as possible after that 8 weeks. If if their symptoms have gone away, then just wean off of it. But if their symptoms come back, you know, and then you need to look for other things causing it, and if they're better on it, they may need to be on it longer term.
Yeah. I tell my patients, we don't really know until we try if you've been on it for a good 2 or 3 months. But we as physicians are not always good at stopping medications, right? I just had this conversation with a patient today. He's like, I've been on omeprazole for 15 years. Do I really need it? And we just aren't great at reviewing that, right?
Yeah, absolutely.
Okay. A viewer in Rapid City is wondering what is normal for how often to have a bowel movement. Is every 3 days abnormal or considered an issue? We addressed this a little bit, but can you review that?
Yeah. So kind of 3 per day to 3 per week, but it's if you're not making sure you're feeling as though you empty out completely, you're not straining, you're not spending an excessive amount of time in the bathroom, those would be some of the things that we would want to kind of follow up on.
Good. We have a viewer in Sioux Falls wondering if we could discuss C. diff. What are the causes? What is the treatment? And what are the outlooks for someone who has it? So C. diff is fairly common. When do we usually see this, Teresa?
We usually see C. diff after antibiotic use. And so it ends up being a lot of diarrhea, treated then with antibiotics. More of a
different antibiotics.
Right, different antibiotics, more of a medical diagnosis and treatment, and so
it's out there, and it can be frustrating. There can be recurrent C. diff, and some patients will really struggle. We also perform stool transplants, so we take healthy donor stool and we put it inside the colon to kind of repopulate, and people have done that for thousands of years, and it works. So, but that's only after a patient has tried and failed 3 different rounds of an antibiotic for C. diff.
Gotcha. So if you've had recurrences, it's important to sort of take that next step and maybe see a specialist about that. We had a viewer ask if anyone has heard of the book Fiber Fueled, and if so, what do we think of that person's advice? I've not heard of it.
I have
Anyone?
not.
Okay,
No.
sorry, that's an easy one. A viewer's wondering if we can explain, I think they mean collagenous colitis is, I think, what I'm interpreting this is. This person is having trouble getting information about collagenous colitis. So can you tell us a little bit about
so
that?
collagenous colitis is a form of microscopic colitis. So I go in, this patient's having a lot of diarrhea, we perform a colonoscopy, everything looks normal to the eye, but underneath the microscope, that collagen band is thickened, and that prevents water from being reabsorbed. We see this, unfortunately, in middle-aged women. It can be related to certain medications such as ibuprofen, aspirin, Aleve, medicines for depression, proton pump inhibitors. It can be associated with, and its brother, lymphocytic colitis, can be associated with celiac disease as well. So we would perform testing for that. And then treatment often involves a mild steroid called budesonide or Entocort. And it's a nuisance diarrhea because it comes back 50% of the time. It can be very frustrating to treat.
Good. A Brookings man is thankful for a colon cancer screening he received before it was too late. Prairie Doc reporter Carter Schmidt sat down with him to hear his story.
Former South Dakota State University baseball player and lifelong Brookings resident Billy McMacken was hesitant to get his colonoscopy when he turned 50 years old in 2019. However, something told him to do it.
You just never know. But I had felt wonderful. But I got in touch with my doctor and said that I'd like to do a colonoscopy. Could you help me set it up?
He had the screening done within a week. It was a quick and easy process, but some unexpected news came from his doctor.
It appeared to be cancer. There appeared to be a tumor. They would have to sample it, and pathology would determine whether it was cancerous or not. This was on a Thursday, and our doctor said I really wouldn't know till Monday officially, but his advice was hope for the best, prepare for the worst.
It was confirmed to be colon cancer and developed to stage 3 within 10 to 15 days. The treatment plan included chemoradiation, followed by surgery.
I am, a little more than 2 years later, no cancer in my body right now, feeling great. So I'm very lucky. I feel real blessed. And if in looking back, if it wasn't for that decision to get a screening, I don't know what would have happened.
McMacken says the recovery was tough at first, but has gotten much better.
Now I'm to checkups every 6 months. I do blood work, and then if that's fine, then 6 months later I do a CT scan.
He has made it his mission to educate others about the importance of getting screened.
There is just no reason to not do it. And I think 20 to 30 people have either texted me, emailed me, written me cards telling me that they have gotten screenings because of me, because of my story.
He says he should officially be cancer-free after 5 years in remission if there are no complications.
Hopefully 3 years from now, I'm getting the blessing of truly being cancer-free.
Oh, thanks, Billy, for helping us with that segment. Interestingly, on this topic, we have a viewer who wants to know about accuracy of a virtual colonoscopy and if the results can be fully trusted. This person had difficulty, it sounds like, with colonoscopy because of a twisty gut, they wrote. So what is a virtual colonoscopy or CT colonography? We don't use them very often, right, Christy?
No, it's been quite a while since I've ordered one.
Yeah.
So patients who are unable to go sedation, have difficulty with the prep perhaps, or have had a challenging incomplete colonoscopy. So it is a CT scan. That patient still has to prep, drink that half gallon or a bit of Miralax and Gatorade. It's very good for polyps less than 1 centimeter in size, so it is reliable. However, if we find a polyp, that person will still have to undergo a colonoscopy to remove that polyp.
Right. Okay. So okay for screening if it's clear, but then you got to kind of move on and go get the polyps if you see them. Teresa, let's talk a little bit about gallbladder disease. We haven't hit that yet. I see this so commonly. Tell us about what symptoms people might get if they're having problems with their gallbladder and how we figure that out.
Okay, so gallbladder disease is extremely common. About 5 million people have their gallbladder taken out every year. Symptoms can be super variable. Some people have the classic symptoms of this, what we call biliary colic, where they eat something and then 20 minutes to a couple of hours later, they start having severe pain. The pain can be in the upper abdomen, more to the right side usually, but sometimes right in the middle, and it can even go around to the back. They'll describe it as this pain where they just cannot get comfortable, and the pain can last anywhere from just 20 minutes to several hours. Usually is accompanied by nausea and sometimes vomiting. Usually no fevers or chills, and then the pain just will go away on its own. Other people have more of a functional problem with the gallbladder, and so their symptoms can be a little bit more vague. Sometimes that bloating that we had talked about before, where they just don't feel good after a meal. And then sometimes they describe the squeezing sensation. And so very variable, but some classic symptoms in there too.
Sure. And how do we look at the gallbladder? How do you figure out if the gallbladder is the cause of someone's symptoms in those cases?
So there's some tests that can be done for the gallbladder. The first one and the easiest one to do is an ultrasound, and that shows us more of the structure of the gallbladder. If the person has stones, if the wall is thickened, we can look at the ducts that connect the liver, gallbladder, pancreas to the small intestine and see if they're dilated at all. Then if that would be normal, we do go on to do a HIDA scan, which is a scan that shows us more of the function of the gallbladder. And so we use it's nuclear medicine, and we use a tracer that goes into the gallbladder and then use another medication that's mimicking them eating. And so it makes the gallbladder contract, and when the gallbladder contracts, we are able to assess how well it's contracting.
Yeah. And if that's all abnormal and we think their symptoms are bad enough, then you talk about surgery,
then
right?
we talk about surgery, exactly.
Common surgery that you do. We had a Facebook viewer who asked if you had the start of Barrett's esophagus and are taking Protonic, so a brand name for a proton pump inhibitor, but you don't need another scope for 3 years. Is it common to wait that long? So what's Barrett's esophagus and what is appropriate monitoring for that?
So Barrett's esophagus is replacement of the normal lining of the esophagus with stomach lining. It kind of starts to creep up the esophagus. And it is a precancerous condition. And it's pretty rare for it to change into cancer in women. We typically see Barrett's in men 60 years old, smokers, drinkers. Protonics, pantoprazole is a perfect medication, and yes, guidelines say after that patient has had an endoscopy or EGD, it is appropriate to wait 3 years for the next upper scope, because the rate of that turning into cancer, if it's what we call short segment, is very low, less than 0.5% per year if it's less than 3 centimeters.
Okay. And these are people that probably we shouldn't take off their proton pump inhibitors, right? There are some people that should stay on them.
Yeah. And it's really the only thing that will help prevent esophageal cancer.
Yeah. Good. We have a viewer from Mobridge who said they have an overactive bladder. Their doctor suggests surgery. So I don't know if we're going to be able to hit bladder questions here. How about, do you have any advice for people who maybe wake up in the night with bowel movements?
That's a warning sign.
Yeah.
So that patient I would recommend talking to your primary care provider and probably a colonoscopy or further workup of that symptom.
Yeah. Okay. We also had someone from Watertown who wonders if 11 days is too long between bowel movements. That's probably abnormal, right?
That's a little bit long.
Yeah. It'd be surprising for someone to go that long and not have pain, I think, right? And other symptoms. Good. So we have another question talking about abdominal hernias. So another common thing that Teresa deals with. So what's a hernia? What kind of types of hernias are there?
There are a lot of different types of hernias. A hernia is a hole in the strong layer of the abdomen that we call the fascia. It is the connective tissue layer that kind of gives our abdomen shape. So our muscles are surrounded by connective tissue, and common places for people to get hernias are in the groin area or the inguinal region, as well as at the umbilicus or the belly button. The reason being is because there were holes there to begin with when we were developing, and so then on males, the testicles start up in the abdomen, and then they go down into the scrotum, and so there had to be a hole there for that to go through. And so if it doesn't close completely, they're at risk for developing a hernia.
Yeah. And sometimes we do surgery. How do you advise people with a hernia whether they should or shouldn't have surgery?
Well, taking the patient into consideration first, of course. Some people are good surgical candidates and some people are not. But if they are a good surgical candidate, then it really goes based on their symptoms. If the hernia is bothering them at all, then it is a reason to fix it. Also, if it's getting larger, a hernia has a higher possibility of staying fixed if we fix it when it's smaller rather than a larger hernia that then has to be pulled together and has more tension on it.
Okay, good. We have a question, another esophagus question. So a Facebook message, someone who has eosinophilic esophagitis being treated with omeprazole 40 milligrams twice a day. Is that someone, should they stay on it forever? How long should they stay on it? Is there something else that they should take?
Yeah, EOE, we shorten it up because that's a mouthful. It's a common condition we're seeing, especially in younger men, often associated with allergies and asthma. So does that person need to be on something? Yes. Twice daily, it depends on symptoms. What we worry about in these individuals is over time scarring. And that means we have to stretch the esophagus. So that patient will need follow-up and need to be seen by a specialist or a surgeon to help monitor that EOE.
Yeah. But another person that should stay on a PPI long term.
Absolutely.
And probably not stop it. You mentioned scarring and stretching the esophagus. So tell me what symptoms people might come in with if they do have some scarring or what we might call a stricture. What symptoms do people get?
Intermittent sensation of food getting kind of stuck as a person is swallowing. It's not one where it goes down the wrong pipe and you cough, but truly they'll point and say it's not going anywhere. And sometimes people will try to force it up and regurgitate it and vomit, and sometimes it is stuck and we have to go in the middle of the night or afternoon and pull out that piece of chicken and etc. And so those are some symptoms. Or pills that get stuck is another common symptom.
Yeah, and so when people come to their doctor and tell them about that, just by hearing it, we don't know if that's scarring, if it could be a mass or something more concerning. So really, we send them to the specialist to think about a procedure. If you see scarring, or when you're doing that EG day, what might you do? How do you stretch it, Teresa?
We're able to stretch it with balloons that goes down into where the narrowing is, and then we're able to pump that up with water and stretch it and watch while we're doing it to make sure that it's not stretching too much at one time, and also that we are getting a good stretch of the area.
And probably take samples most of the time of tissue, make sure there's not something like cancer or something more concerning. Great. We have someone asking about gastroparesis. So can you tell us, what is gastroparesis?
So, it's a Greek word for slowing of the gut. So the gut just doesn't want to do its job of emptying properly. And so patients will feel full, what we call early satiety, nausea, abdominal pain, bloat again. And so why do people get it? The most common reason is we don't know, but it often is associated with diabetes. We can see it with medications as well, and also with marijuana. And so that's also something we're starting to hear about more frequently.
Yeah. That's a great point. I think a lot of people think of marijuana as something that helps nausea and vomiting, but in some cases it can actually cause a vomiting syndrome. Is that right?
Something called cyclic vomiting syndrome. And it becomes a really vicious cycle because they're nauseous, they smoke more marijuana, they feel a little better, they eat a lot more, but the stomach is not moving. So it is a tough situation.
Yeah. My experience is people don't usually believe you when you say the cure is to stop it. Okay. We have someone who had a grandson with chronic vomiting and they haven't been diagnosed with a cause. What causes chronic vomiting, maybe in kids or teens? Can you think of any major things, Teresa? I don't know the age of this child, but
well,
vomiting can be tough.
It can be very challenging. I mean, gallbladder, EOE, ulceration, even constipation. And you're talking to an adult GI, so
I know. It's not really fair. But I mean, vomiting's not fun, so usually people don't tolerate that for very long before they're seeking out more care about that. We had a viewer who sent in an email wondering if we could talk about IBS or irritable bowel syndrome, symptoms and treatment. So can you tell us a little bit about IBS?
So IBS is really common. 10% of the population will have IBS. So it's change in stool pattern associated with abdominal pain. And that stool pattern could be diarrhea or constipation, or sometimes a combination of both. And so the pain typically will go away after that bowel movement. Treatment, we start with looking at diet, and then there are medicines. So if a person is having diarrhea, we can slow things down. On the flip side, we will treat constipation as well.
And different than IBS, what confusing is IBD. So we have like a minute left. What's the short version of what's IBD and how's it different?
Inflammatory bowel disease, bloody diarrhea and abdominal pain, an autoimmune condition, which would need a lot more intervention and attention.
And so often blood and pain are more prevalent with inflammatory bowel disease. We did have one question about, is smoking a risk factor for colon cancer like it is for lung and other cancers, Teresa?
Yes, just the carcinogens that are in the tobacco products, it makes it a higher risk.
So numerous cancers can be related to smoking, and sounds like colon cancer is one of them. Do all colon cancers require chemotherapy and the whole gamut, or if we find it early, can we treat it just with a surgery?
There are some times when it's found early that it is able to be treated just with surgery. You still do need to follow with an oncologist, of course, after a colon cancer is found. You also need to have colonoscopies on a regular basis after having a colon cancer.
Higher risk for not only that one coming back, but developing another one in the future, right? Great. All right. We have a winner of our question drawing tonight. This is Annie from Oneida, South Dakota. Thank you, Annie, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this. In the last couple of years, I have developed a renewed awe and appreciation of our scientists around the world who work for entire careers to advance science and medicine in their laboratories and beyond. One such scientist is Dr. Barry Marshall. Marshall is an Australian physician scientist who in the early 1980s, along with his cohort, Dr. Robin Warren, initiated a paradigm shift in the world's understanding of gastrointestinal disease when they discovered the bacterium Helicobacter pylori. Prior to that, peptic ulcer disease was thought to be due entirely to lifestyle factors and stress. Marshall and Warren were ultimately able to show that H. pylori played a major role in maybe 80% of ulcers worldwide at that time. H. pylori is an unusual bacterium in that it can grow and thrive in a highly acidic environment, like the stomach. And for that reason, it was difficult to grow in culture. It was found to be widespread around the world, partly due to poor water sanitation systems. The bacteria can invade the surface of the stomach and duodenum, causing inflammation of the stomach or gastritis, ulcers, and even rarely stomach cancer. We now know that if H. pylori is a causative factor in a patient's stomach ulcers, eradication of the bacteria is an essential part of curing the patient's disease. Now, here's the greatest piece of this science story. At the time Marshall and Warren made their discovery, the worldwide scientific community was skeptical that H. pylori was an important factor in peptic ulcer disease. H. pylori did not grow in mouse or rat stomachs, so there was not a good way to study it in a traditional lab. Famously, in 1984, Marshall underwent biopsy of his own stomach, proving he did not carry the bacteria nor have any stomach disease. Then he drank a beaker of H. pylori culture broth. What followed was an acute gastric illness, and after 2 weeks he had another biopsy showing proven H. pylori infection and gastritis. He then cured himself with an antibiotic and bismuth. After Marshall's case study was published, much further research ensued. Today, we can detect H. pylori in our patients with several non-invasive testing strategies, and if detected, treat them with a combination of antibiotics and acid-reducing medication. Surgery to remove a portion of ulcerated stomach, commonplace prior to his discovery, is now incredibly rare in the developed world. In 2005, Marshall and Warren were awarded the Nobel Prize in Physiology for their detective work. I wonder, had Dr. Marshall not risked his own health for his experiment, would our understanding have shifted so quickly? Maybe, maybe not, but the story sure wouldn't be as captivating. A very sincere thank you to Christy and Teresa for volunteering to visit with us tonight about the problems and treatments of our digestive system. A reminder for all of us, we are entering the influenza season here in the upper Midwest. If you're getting a COVID vaccine, it is safe to get the flu vaccine at the same time. Please make plans to get your flu shot soon. As we continue to celebrate our 20th season, we invite you, our viewers, to tell us how this program has made a difference in your life. Please email or mail your story to the addresses on the screen. If you would like to see and hear more episodes of this program, please like and follow us on Facebook and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. And as we celebrate our 20th season of truthful, tested, and timely medical information, from all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Few things warm the heart like a mom with a newborn. Unfortunately, disease, accidents, and domestic violence pose risk. Protecting Mom, next time on Call with the Prairie Doc, celebrating our 20th season.
I grew up on a farm near Wessington Springs, South Dakota. All my life, I've been an advocate for rural communities. One of the major challenges we face is providing reliable and easy access to primary health care. Hello, I'm Dr. Tom Dean. After completing medical training nearly 50 years ago, my wife Kathy and I came back to Wessington Springs to provide health care and to raise our family. Just like you, we love our small town. I serve on the Healing Words Foundation board. This year, we celebrate the 20th season of the Prairie Doc. Rick and Joni Holmes started this mission of providing objective, evidence-based healthcare information free of charge to everyone, especially to people in rural areas who may have limited access to healthcare professionals. Truthful, tested, timely medical information for 20 seasons. That's the Prairie Doc, and it's up to us to help to continue that legacy. Please give to the Healing Words Foundation. Go to prairiedoc.org and make your donation today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
South Dakota Academy of Family Physicians,
Avera Heart Hospital,
First Bank and Trust,
Dakota Allergy and Asthma,
Vance Thompson Vision,
Monument Health,
Black Hills Medical Society,
Brookings, Madison, Flander District Medical Society,
Pierre District Medical Society,
Yankton District Medical Society,
Orthopedic Institute,
Lake Poncet Sailing Academy,
Aberdeen Asthma and Allergy,
Dakota Bank,
South Dakota American College of Physicians,
and Swiftel Communications.